All right, I think we're about ready to go here, if it works for your guys' schedule as well. It's good to be here with you guys. Man, this is good memories, I have to admit, just kind of standing here. Did that for quite a while, and it's good to be back with you guys. So if what I understand, you've already been through a fair amount of the basics of evidence-based medicine, and Ashley's asked me to come in and talk about one specific topic, and that's decision analyses and how those work and what they're all about. Before we dive into that, though, let's have a word of prayer as we get started. Let's bow our heads together. Father in heaven, as we study some principles of evidence-based medicine, we'd ask that our minds be clear and that you would help us to understand, and most importantly, help this to be one more brick in the foundation of knowledge and skills of each of these PA students, and help them to develop into outstanding, compassionate clinicians. We thank you for this. In Jesus' name, amen. So, practice guidelines and decision analysis. Actually, I don't think practice guidelines is actually something that you really want me to go over, so...
We kind of talked about it already a little bit as well.
You already talked about it already. That's perfect. And those are really helpful. And just to review, and maybe I'll ask you guys, it's on the screen, but you can help me out. Remind me on the practice guidelines, give me kind of a vibe of what are practice guidelines, because I'm going to contrast the decision analyses versus them. Practice guidelines, what are those? What are those practice? And no penalties for slightly, different answers there, okay? Safe room, safe environment. At least I think that's the hope. Okay?
Isn't it kind of just like a decision tree? Like you need to start here and then go down?
Kind of like a decision tree. Often they can be, often can be formatted like a decision tree where there's certain recommendations coming out of a group and then you follow kind of stepwise through there. And if my patient has this factor, then I should do this. And if they have a different sort of a situation, I do something different. Absolutely, that can be a very common format. Where do the practice guidelines come from? Who authors them? Have you guys heard about that at all? Have you seen any practice guidelines at all? Probably not. You may not have yet. And that's okay.
I looked up the clearinghouse.
Like a clearinghouse of some type? You looked at the National Clearinghouse of practice guidelines. Very nice. Foundationally, often those come from like a physician practice group, like the American Academy of Pediatrics or the American Academy of Family Practitioners. And usually those groups will forge some sort of consensus from all of their, usually their board of governing body on a particular topic, and they'll vote that in and then publish those. An important point is that they may or may not rely on precise quantitation. In fact, historically, they did not. For a long, long time, they didn't really use precise quantitation. Now, why do I say that? Is because that's the entire point of a decision analysis. By definition, a decision analysis is quantitative, and it uses very explicit, freely published rules that it abides by to come up with a kind of a quantitative answer to a clinical situation. And that probably sounds like, oh my goodness, what is this all about? We'll walk through one here in just a second, but the most important point you should keep in your mind right now is that decision analyses basically use math to help you solve complex clinical problems. Okay? So that's the big picture there. Now, a couple of nice things about them. One is they are very much open for debate and modification, and what that means is they usually publish exactly how they did everything. And so if someone takes a look at it and says, hey, I'm not sure if I totally agree with the principles that were underlying your math, I think they should be tweaked in some way. That's easy to do because they publish all of their methodology. On top of that, because of their explicit way that they're done, and this will make more sense in a minute, these are the ones that really inform clinical policy. What's clinical policy? Well, this is often actually even how insurance companies will reimburse. I was just thinking to myself, it's been a while, but Bronson Riley is teaching your medical genetics class, right? he used to come in and guest lecture for me whenever I was teaching the medical genetics. And I remember him showing, and I'd be surprised if he didn't show it to you guys as well, did he show you any of the kind of raw guidelines that you might have to go by if you wanted to get someone reimbursed for having genetic testing? Like, for example, it might say, recommended genetic testing if the patient has a first-degree relative that's had a particular kind of cancer, or if they've had 2 secondary relatives and this, or 6 third-degree cousins, and it goes on and on. It's like a page long, right, forever and ever and ever. Well, if you're curious, where does those come from? Does some person in some back room just scribble those out? No, actually, it comes from this. It actually comes from the decision analyses. What we're about to do is what underlies where those things come from. Okay? That also means it actually informs often how insurance companies reimburse. Now, I'm not here to defend insurance companies because they can often be the bane of a clinical practitioner. However, frequently, if you're within the boundaries of decision analyses, it is almost guaranteed reimbursement occurs. If you're outside the boundaries, in other words, if you're kind of recommending things for your patients that are well outside what are the kind of the calculated decision analyses for that area, sometimes those things won't get reimbursed because the insurance companies kind of religiously stick to that. Questions so far? I know we're kind of vague and at the very kind of top level, but any questions so far? Comparing and contrasting to what you guys already know. Okay. All right. Well, then let's go ahead. And by the way, I forgot to mention this. And this hopefully does not suppress any more questions. I always like to record the lecture. And so what this is recording is both my voice. It might pick up on questions a little bit, but certainly my answers, and also the screen. So it'll record this, what we do, the math and stuff like that. And then I'll post it and give a link to Ashley, and you guys can have it for review if you want to review that while you're working through your signs and stuff. Okay? Questions? Yeah.
This might be silly, but so we talk about practice guidelines and published in the clearinghouse. What about decision analyses? Like, where do insurance companies, is there a common form?
A common location where the decision analyses are at? That's actually a really good question. I almost might lean on Ashley as a clinician of where you might find them. They often are also in any centralized storage of systematic reviews. Because, did you guys, I'm sure you did you guys do like that pyramid of evidence where you've got different levels of evidence all the way down, and you got really low level, and you got really high level, and like at the very top, what was at the very tippy top of that? Systematic reviews. Yep, exactly. This would fit in that top category. So for example, like the Cochrane database of systematic reviews, you can often find actually decision analyses in there, in other locations. I don't know if you have anything else to add to that, Ashley.
I think to me, a decision analysis is what it brings guidelines based on benefit and risk. And so,
Right.
You may see guidelines that give you that data for benefit, and then you may see guidelines that give you that information for risk. And a
Right.
decision analysis kind of blends the two in order for you to balance benefit versus risk.
That's super helpful. I think what she's asking, though, is are there any databases specifically that, like a centralized source of these? I mean, whenever I looked for these, they were most often found, are you guys using either Medline Complete or any of the other searchable databases? You can actually often limit your searches to decision analysis, or even just use that as a keyword in combination with the other factors you're searching for, and that'll pull them up as well. Now, importantly, you will not find decision analyses for a lot of topics, and here's why. They are really hard. They take a lot of work for the researchers to put together, so they only put them together for things that are relatively common. If you as a clinician are doing this 10 times a day, you might find a decision analysis on it. If you look at something once every few months, there might not even be a decision analysis for that because of the challenge of creating it, and also you need to have a lot of evidence, a whole lot of evidence to be able to produce one. Okay? Good question, though. Very good question. All right. Okay, well, let's go ahead and move forward, I think, here, because we're going to do a little problem together. This, by the way, I think they actually uploaded this into your drive. These are actually pages from the older textbook. And oops. Oh, no. That's not good. Get back? Oh, sweet. All right, perfect. Actually, that's one thing I used to hate about this room, and I'm very superstitious. Okay? No, I'm actually not. I'm actually the opposite of that. That's why I love evidence-based medicine. But at the same time, I do have some concerns that there is like excessive electromagnetic radiation that emits from this, because I like to play with lots of technology, and this room especially had some challenges. So, we'll see if little ghosts in the ether mess with the projector or not. All right. So here is, this is actually a little diagram. I wonder if they actually give me the clinical case here on the next slide. Let me just pull it up if it'll let me. It's kind of blank there. I don't know why. Oh boy, this is scary. I did not double check that it had everything there without uploading it. Really? That's interesting. Wow. Okay, we may be winging this one. Whoa. Because I'm expecting like about 4 or 5 more pages there. So I can describe things really well, but it would be helpful if I had those pages. Okay, well, let's see how this goes. In fact, I think I might be able to do it in a way that I could use this if I had to. I'll start off the description here. Basically, here you have a patient with AFib, right? And you guys, I'm sure, learned in pathophysiology something to the effect of when it comes to formation of clots, there are various things that can cause clots in the body, like Virchow's triad, right? If you picked up on that. And those 3 things are what again? Just to review, to kind of bring patho into a situation here. What are things they can cause? Because one of them... Stasis. Yeah, so definitely stasis. So endothelial damage, right? Yeah, okay. Yeah, so hypercoagulability. And then this one right here is it's basically turbulence in the blood, right? Turbulence, any sort of turbulence, excessive turbulence can also then trigger. So AFib, the atria are fluttering there, and as they flutter, they add even more turbulence to the blood that would normally be happening as they go through the heart. And so patients with AFib are at high risk of having a clot, and so as a result, you might end up having a stroke from that, because that clot, the first place it might go is right up the carotid arteries, right into the brain, and lodge, and then now that patient has a stroke. So here is basically, when you're looking at a patient with AFib, you get 3 options for treating that patient. You have 3 options. You could give them nothing, okay, so no treatment. You could give them aspirin, or you could give them warfarin. And here's the trick. It actually varies on patient by patient which one of those options is the best. It's not like a no-brainer where you just go, oh, it's always warfarin, or it's always aspirin, or it's always no treatment. It actually varies a little bit on the patient. Okay. With each of these, there are basically 4 options that could occur to that patient. Okay? And those 4 options are, this patient, after I give them either treatment or not, over the next few months, they could have the great outcome of not having a stroke, hallelujah, and then also not having kind of that side effect of a bleed, right? Because a bleed would be from the other 2 drugs. As you thin the blood, you kind of increase the risk of a bleed. You might have a GI bleed, and that could also be fairly bad for the patient outcome. They could have a stroke and then not a bleed. They could have no stroke and a bleed, or they could have the worst possible. This is like the most unlucky person of all time. They could have a stroke and a bleed, right? Those are literally all of the possibilities that could pop up for that individual. So I'm going to pull up on my screen over here some of the numbers that are going to come with all of this, so I can take a look at it with you. See, there actually is additional pictures, and probably on yours as well, that for some reason aren't popping up on.
Trying to upload them.
Okay, they don't actually have those other ones. That's okay. That's actually perhaps better in some ways. Kind of working blind here a little bit. So here is the interesting the way the decision analysis works, and that is it begins to apply some numbers to this. And what it'll do is, let's take a very particular patient. So, and I don't have the details in front of me, but let's say the patient was, 67 years old. They are a smoker. They have not had a stroke or other event at this time, although obviously they have the AFib. So now we have a very particular patient. Well, you could plug those into some various calculators, and actually probabilities would emerge. And let me show you what those probabilities might be. So I'm going to start writing them down for you. So for example, if I don't give my patient anything, the no stroke, no bleed would have a probability of 0.891. This is going to be probability. And if you guys remember probability from your stats courses, we could convert this into a percent if we wanted to. So that would be 89.1%. And then a stroke is actually, if I don't treat them, and again, this is for this particular patient we've calculated, 0.099. Okay, so about 9% chance of a stroke. And it's over a particular period of time. It's always limited with the next decade or something like that. No stroke, no bleed. All right, 0.009. So even about 1% there. And then stroke and bleed, the worst of all time, 0.001. Okay, these are all probabilities. If you notice something, do you guys notice that this adds up to something? What does that add up to? It adds up to 1. And what does that mean? We pretty much trapped reality. One of these 4 things will happen to this patient. Does that make sense? You have to have one of these 4 things, right? You're going to be fine, or you're going to have one of the bad events, you're going to have all the bad events. Right? There's just no other options, okay? And we can do this actually for all of the options. Let's go ahead and do that actually. I'm going to walk through and I'll give you some more. So for the aspirin, what does it come up to? Let's see, 0.915 it looks like. How do I have to squeeze it in here? 0.915. And then 0.064. 64, no stroke, no bleed is 0.02. By the way, get ready. I'm going to ask you guys, after I write these probabilities down, to make a call for this patient, right? You're in the clinic with them. You got to make a decision. Are you going to give them nothing? Are you going to give them warfarin? Are you going to give them aspirin? I'll call on a few of you to kind of get your analysis at that point, okay? So 0.2, sorry, a little unclear there, 0. Oh, good. So if you want to pull that up, you can actually see what we're doing here, as well as on the screen. 0.01. Oops, I actually need to put another 0 in there. 0.1. That makes more sense. And then in my last one, I'm going to do the warfarin. 0.939. 0.02. And 0.04. And 0.001. Okay. So, we now have them up there. Let's see if I can get them all on the same kind of screen a little bit. I think I can. You have your, this is, by the way, this is real stuff, right? This is like 1 year from now. You're in clinical rotations. You're making this decision in collaboration with your preceptor. Which way are we going here? Okay. What I want you to do is, and by the way, there's no right or wrong answers at this point. I haven't given you all of the information, so you can't get everything perfectly right. So what I'd like to hear is just which option would you maybe lean towards, and what's kind of in your head as you lean towards it. And I bet you some of that will lead us towards what are the rest of the principles that govern a decision analysis. So, yes?
I'd pick warfarin because they have a higher chance of no stroke, no bleed, and then they also have a lower chance of getting a stroke but having a bleed versus aspirin, they have a higher chance of a stroke.
Okay, you did a lot there. We got to unpack that. Woo, my goodness. Okay, because I think there's, and we'll get right to you. So you said down here, number 1, that you like this one because this one had the highest chance of a no stroke, no bleed. That was the first thing you said. So like I compare up here, this one's like almost a 94% chance of that. The no stroke, no bleed up here is at 91%. 1.5%, and then up here it's only an 89%, and you're gunning for my patient to have the best possible outcome, so I'm going to go with that.
And then in the second line, they have a, 20% chance of a stroke with no bleed, whereas aspirin has a, 64%? Or 6%. So they have a 2% and a 6%.
Mm-hmm.
So I would say that one has
Stroke,
less
and so,
likely having a stroke.
this is actually going to be really important in my next thing. What you're saying is strokes are bad. Okay, I'm sorry, I'm not trying to be oversimplified here, but you're actually applying some values in that these are not equal outcomes, if that makes sense. Like some things you might want to avoid more than other things, and so like the stroke is like the worst possible thing that could happen to this patient, so we want to try to avoid that, and the stroke is the least probability down here. I like that. Okay, go ahead.
Well, I was just thinking the first question I want to ask is, are they on any other medications? Because we've learned
Oh,
that
right.
warfarin has a lot of drug-drug interactions.
Absolutely right.
So since, it's a 91 versus a 93 or 4% chance.
So maybe that might modify some of this. And that's absolutely true. That would be absolutely true. In this situation, we've kind of simplified it down to the point of which we're assuming these probabilities take into account the entire clinical situation of the individual. But I hear you on that. I mean, medicine is very complex, so there's a lot of factors there. But yep, that could also play into this without a doubt. Well, I want to go back to your point, because, boy, that's just such a perfect lead-in. Do you guys get that point that not all outcomes are the same, right? Like, in other words, if I end up with a stroke, that could be worse potentially than the bleed. And, of course, the bleed might still be worse than if I had no stroke, no bleed, obviously. And a decision analysis will actually quantify those outcomes. And there's this weird little thing they call utility. So the utility, okay, and utility is a quantitative measurement of quality of life for that outcome. It's on a 0 to 1 scale. 1 is perfect quality of life. 0 is death, basically, right? There's just nothing there, okay? So we can actually apply those numbers in, and it's right there in my little notes. If you can see those there, make mine bigger so I can see that. Okay. So, for example, all of the utilities for no stroke, no bleed are 1. And then the stroke, no bleed, is going to be 0.5, because basically what they're saying is, on average, a stroke leaves someone with roughly half the quality of life that they had prior to the stroke. Now, obviously, some strokes are very mild, may not be very much impact. Some strokes are extraordinarily severe, might even kill the patient. So they have to take an average of this, because we're dealing in probability, so approximately half. And then no stroke, but you have a bleed, on average, you might decrease the quality of life by an individual down to about 80%. And then lastly, stroke and bleed, this is the absolute worst possible situation, about down to 0.4. Okay? That makes sense? And then that would be just repeated all the way down if I were to fill those in as well. So just a 1. And I'm going to ask you guys to pull out maybe your phones in a second here, if you can go ahead and do that, or anything that you can do a calculation with, because we're going to do the math together. And I think this is exactly what you have to do for your homework, so if you practice it now, this might make your homework relatively simple, hopefully. Bless you. All right. So here's what we need to do. We're going to do something kind of odd. We're going to take the utility and multiply it by the probability. Okay? And then not only that, but we're going to do that for each one of these, and then we're going to take whole options, in other words, all of the prophylactics, and we're going to add up that number. Okay? And then the same thing for the aspirin and the warfarin. So let me just have maybe some assistance here. Who has calculators out ready to go, everybody? Let me take maybe this group over here. Would you guys even double check your math? Run down the first one, the no prophylaxis, kind of like top to the bottom. You need to write the numbers down as you do it, and then I'll write them in here. If you guys could do my aspirin one, and then do you guys mind doing the third one down, the warfarin? So just take the numbers So I can obviously do the first one. I'm going to start with this group here, though. First one, of course, would be 1 times this is 0.891. And then you guys give me 495, okay?
No, I didn't.
It's 0.0072. Yep.
72, and then give me one more.
0.00004.
So 4 zeros,
No, only 3 zeros.
3 zeros,
Yes.
and then 4, like that. And then now somebody in your group add that whole, those just, not multiply them, but add all 4 of those numbers up. 1 point, what was it again? 39 even. Okay, double check that. And then you guys, you're working over some numbers on the middle there. And you can do this yourself, just to kind of double check your own. So I know, of course, the first one was 0.915.
And the second one's 0.032.
032.
And then 0.016.
062. 16, I'm sorry.
Okay.
Oh, 16?
Yes, 1/6.
One's like this.
Yes.
Oh, but there's a 0.
One,
My
yes.
goodness, you can coach me through this. I tell you what, I'll get it sooner or later.
And then 0.0004.
0, 0, 0. So 3 zeros,
Yes.
4.
And the total is 0.9634.
All right.
I got 2.
0.9.
634.
Perfect. Okay. All right. I got one last one here. This is the warfarin one. Again, this is always the easy one. Oops. Hold on now. There we go. 939. 0.01. Okay. What else do we got for the third one down? 0.032. And then
0.0004.
so 3 zeros. Okay. And then what's my sum of these guys?
0.985.
Okay. 985. Okay. All right.
I don't know if our number was right.
Yeah, it's okay. Let's come back to that number and just double check. See if you can add that up. And is this? I'm just wondering on this stroke no bleed number. Come over here and do my.
0.9481 is our,
Is the total
yeah.
0.9481?
Yeah.
0.9481.
That's what you got. You just add them together.
That feels about right.
That's right.
Intuitive. Okay. Hey guys, you might be wondering like, oh my goodness, the dumb little screen is full of math and I don't know what's going on here and why are we doing this? And there's no point to this. Actually, there almost is. Are you ready for this? Are you ready for this? I'm going to drop some truth here, okay? Here's the key point. What we just did is we multiplied the quality of life for each of those options times the probability. And when we added those up, we now have this funny sort of additive number that tells us for each of the treatment options, the prophylaxis, the aspirin, or the warfarin, what is the probability of quality of life for each of those options in total? And the higher the number, the higher the likelihood that patient will have a high quality of life. We have mathematically come up with an answer to our question. So now you can help me rank these. Which of these is most likely to produce the highest quality of life? Warfarin. Which one is least? No treatment, because that's a 4.9481 there. And then in the middle would be aspirin. Now, first off, lots of caveats here. Number one caveat is one of the core principles of evidence-based medicine is not just that we follow the best evidence, but also something about the patient. What do we talk about the patient there? What happens with the patient values or the patient? You guys talk about that at all? So evidence-based medicine is basically applying the best evidence to any particular clinical question, but incorporating in the same moment the patient's values and perspective. So a patient might tell you, well, I'm really, really concerned about a bleed, and so I want to do whatever I can to avoid that. Or a patient might tell you, look, my personal values is I'm not really interested in any treatment whatsoever based upon just personal beliefs. I'd rather try to take a natural route, do whatever I can on my own, and then you can talk them through, okay, fair enough. Here's the difference between the treatment probability and versus the non-treatment. Here's your relative risk of developing any of these particular outcomes. Does that make sense at all? Okay, questions. We should have questions at this point, at least I hope. So this is just kind of like a very simplified version of it, but this does actually apply to the real world here. I can show you a paper, and I'm pretty sure this paper, did you have this paper, Ashley, the paper on the this aspirin versus warfarin? Let me pull it up on the screen here. Do you have it there? Oh, okay, perfect. Well, you'll have this in just a moment, and you don't need to do anything with it for the short run here. Here is a paper that quite literally is exactly what we were just talking about. Aspirin versus warfarin in AFib, decision analysis may help patient choice. Okay? And then if I come on down here, of course they have the methodology and all this sort of stuff. And they've got even like this really fancy table that is essentially what we just did. This big old giant table here with all these numbers. That's exactly what they were trying to calculate for every single kind of category of patient. And then they summarize it very nicely into this little, in fact, I'll pull it up nice and big here. Here's the summary of their decision tree for this decision analysis. And here's what they've got. On the y-axis, this little, what's this called? I can't think of the right. It's basically a calculator. This is a calculator for individuals, the relative risk that they might bleed. So factors that might go in here is like if they already have some other like hypercoagulable state that they're in, if they're a smoker, XYZ, that sort of stuff might plug into whether or not, what's the likelihood that patient may bleed. The bottom here, this is the likelihood that they might have a stroke. Okay, what's the likelihood of a clot forming? And then here's the key thing. Green is no prophylaxis, no treatment. The yellowish color there, that is aspirin, and the red is warfarin. So quite literally, you have your patient drop in, and you say, okay, let me ask you a few questions. You ask them the questions, you have their patient history, and they might be a 3-1, and if that's the case, we don't give them any prophylaxis, right? Of course, incorporating their values and all that, we talk to the patient, figure it out. What if they're a 4-1, like or down here? Well, all of a sudden, most likely, their best outcome would come from warfarin. If they were like a 7-5 plus, all of a sudden we'd be talking about aspirin. That makes sense? I can actually show you what those calculators look like. And have you guys logged into UpToDate at this point? Oh, yes, see lots of nodding heads, that's good. Hopefully you'll have this in your pocket as you're on your rotations. And also Dynamed, that's, by the way, those are the two that kind of are almost the same, and the college has gone back and forth over time over Dynamed or UpToDate, and the same thing in different clinical groups. You might come into a clinical group that has Dynamed, might come into one that has UpToDate, but they essentially have some of the same general tools. Here is, let me skip over that. Let me see what I got here. Swap that out. Swap this out for this guy. Okay. So, of course, there's UpToDate. Boom. Okay. So when you're at, let me see if I have it. Yep. So when you're in UpToDate, if you click on, do you see the calculators there on the right-hand side? If you click on those, it pulls out all kinds of various calculators. Close that for the time being. And you can actually see that? Does that remind you of anything we just looked at, right? Let's click on that guy. Clinical characteristics comprising the has blood bleeding risk score in adults. So, for example, does my patient have hypertension? Let's say they do. Do they have abnormal renal function? Sure. Are they elderly, greater than 65? Okay. Then you come down here and take a look. It's a 0 to 5 plus scale, and that's exactly what was on our previous slide, if that makes sense. That's how you got that raw number. Same thing actually happens with, here is the risk stratification for stroke risk. Is it a female patient? What age are they? Do they have congestive heart failure? Do they have a history of stroke or anything else, right? Diabetes. Then you come down here, it actually will show you, of course, not even just the point scale, but even their relative risk, or excuse me, their absolute risk of developing that particular event over the next X amount of time, so per year. Questions? Questions? Okay. Does it make sense, right? Does it make sense? So this actually, for anything in the clinic that has this can really help inform the decision-making of the clinician and the patient together at a tremendous level. Because not only do you have like the raw probabilities of what each event might be, but on top of that, you can actually even kind of average those up. By the way, this is kind of like Vegas odds in some ways. It's kind of, I'm sorry to say that, but it really is. Like, think about it for a second. You're going to go in and you play in the casino, and if there's one game that has like a 70% return on average, and one game that's got an 80% return on average, and one game that's got a 90% return, which one would you rather play? Well, I'd much rather play the one that has the highest probability that I can come out on the positive side. And that's essentially what all of these do, kind of comparing those risks versus benefits sort of outcomes. Okay. All right. I think those are the major key points that I was going to cover. Ashley, did I miss anything that you can think of or add to? No? That's fine. That's totally fine. I was thinking something else that I could do for you that if you are interested, I'm happy to answer any questions you have about anything in general, and then, I guess, collectively, but then specifically maybe we could break up, and if you have questions about your capstones, I'm happy to kind of give you additional feedback on top of what Ashley does at a very high, excellent level, just another outside perspective as you guys are trying to pull those together, and if that might help. Maybe in small groups, 3 or 4 or something, just kind of go through that. Questions? Any questions you guys have? Yes?
So this is for, I think the vascular disease one. How many of these type of calculators are there?
There's not a ton. We can actually take a look here.
Pretty nifty. It'd be nice if there was one for all.
It would be amazing if there was one for everything, right? It would be amazing. Here's how many there are. I mean, there's a decent amount. You can see my little scroll bar here. So there's a decent amount. There's a lot of repetition in there. Hey, do you guys, oh, you probably didn't do this. I bet you didn't do this, but one of the assignments that I used to give was, and I'm looking at Ashley to see if you guys happen to do this, was, you're given a patient with, that's got a little bit of high cholesterol, and they're kind of wondering if they should go on statins or not, and so they're kind of weighing their options. Maybe you guys didn't do that one. That's okay, but that would be like, I'll just pull it up here. I'm remembering a clinical situation I did. Oh, goodness. Oh, actually, no. I'm trying to think of what they call that. It was the Framingham.
Yeah,
Oh, here it is, right here. Boom. So the Framingham study. This is that huge study. I forget how many hundreds of thousands of people were in that study. It was a gigantic one over a long period of time. And all kinds of things came out of the Framingham study. But one of the things that came out was for at least certain populations, a relatively good predictor for certain health outcomes. So for example, you could just plug anything you wanted into here. If the person's 36 years old and their blood pressure is 110 and their total cholesterol is 240, this is the numbers I'm trying to remember from before, and then their HDL is 40, and they're not on hypertension medic, they're not a smoker, they don't have diabetes, and then over here, check it out, This is, I believe, I'm almost sure, over a 10-year, yeah, it is, right here at the top, 10-year period of time, their risk of having, I'm pretty sure it's a myocardial infarction, could be, actually I think it's a combination of coronary disease, cerebrovascular disease, peripheral, it's a combination of all those, 3.45%, right? And then you could actually talk to them and say, okay, if we prescribe you Crestor, the probability is on average it can drop your cholesterol by 20% or whatever else. So we might be able to get you down to 200. That will change your risk to 2.82% in contrast to 3.4% over the next decade. And then be able to have a real conversation about risk versus otherwise. Yeah. Okay. I don't want to bore you, so we can go ahead and pause there if you want to.
One thing that I would add to that.
Yes.
These calculators may change and evolve over time, right?
Right.
So each one of these calculators is based on clinical study results that show the incidence of these events occurring over
Mhm.
time. And so, for example, this says
Yes.
Framingham 2008 paper at the top.
Yep.
So it's likely that this calculator was generated and developed based on data from a study that collected information, and was published in 2008. So, there's not going to be just a universal calculator that's there
Unfortunately.
forever
Yeah.
for the eternity of your practice.
That's right. And unfortunately, many of these calculators, like this one, is pretty biased. Like, for example, it's not good at calculating risk for populations other than white Caucasians, because that was by far and away, the majority of the patients that were included in the study. So when we're talking about African American or Asian or other sort of genetic background, this was not helpful in necessarily predicting the outcomes for those patient groups in general. That's at least what I remember. So, yeah, there's definitely limitations to the calculators that you have to be aware of. Okay, well, I'm going to go ahead and pause right there. I'll go ahead and shut down this stuff. And then if you have questions, you want to kind of run capstone ideas, I'd especially, what I'd like to prioritize, I don't know what stage you guys are in, but are you still in the stage of trying to figure out what your idea is at this point? Or are you kind of getting locked in a little bit, working on it, right? Yeah. I always feel pity for the students who are lost. I have no idea where they're going. I feel deep because I want to help them, right? So I always keep a few ideas in my back pocket, and I'm here's an idea. Let's go with that. So if you're in that group, seek me out. We'll see if we can find some different things there. Okay. All right. I'll go ahead and shut this down, and we'll go there. You are very welcome. You bet. Happy to be here.